Danach?
Ja.
So, ich würde die gerne vorstellen, weil
Wir brauchen nur jetzt immer Fluorostor, das war seine Bitte, gell, dass wir es... Okay, gut. Jetzt kommt der Moment, wo wir die Prokleits rein tun. Das heißt,
so IT, can you switch over please to Malta?
Sollen wir nochmal runter präparieren und ein bisschen mit dem...
And switch over the sound. Matthew? Can you hear us, Matthew?
Hi, yes, we can hear you.
Hi.
Can you hear us?
Yes. Welcome to the Austria CHIP meeting.
Thank you so much. Thanks for having us. Welcome to Malta. This is our case for you today. So there's myself, Dr. Matthew Balbi, I've got Dr. Ellton Pllaha and Dr. William Camilleri here helping me today. With us we also have our structural nurses, Christina, Odette, and Maria. We have two radiographers, Charlene and Duncan. We have our ECG techs here as well. So we'd like to start off by showing you a bit of a presentation, a little bit about the case and about what we're going to do today for you. So I'll hand over to William Camilleri, who's going to explain the case, and then we'll run you through everything.
So good morning. Thank you for the kind invitation to your prestigious meeting. We created a small presentation. So we are live here from Malta, from the local hospital, not today. Next slide, please. So a bit of the patient history. This is an 81-year-old female, diabetic, dyslipidemic, and she's an ex-smoker. She's a known case of moderate to severe aortic stenosis. She presents with syncope to us whilst cleaning her roof, and she was prepared for therapy. Next slide, please. The echocardiogram shows a normal LV systolic function. She has a good ejection fraction of 60%. And we have evidence of moderate aortic stenosis, maximum gradient of 3.5 meters per second, and pressure gradient of 50 millimeters of mercury. Her area on echo was estimated at around 1 centimeter squared. Next slide, please. So we did CT planning using the 3-Mercieca software. We did a calcium score for all our patients who are referred to therapy. The calcium score was total gastric score of 1,530, which is people with severe aortic stenosis. She's a female. Next slide, please. Next slide, please. Yes. So we'll run you through the femoral. So we start here at the common femoral, which was nice and clean. But as you can see, as we go up, there is calcium and luminal narrowing of the right iliac artery coming up. There's napkin ring in the abdominal aorta, and she has minimum diameter of 4.2 centimeters. On the left, we have the same story where we have circumferential calcium and luminal narrowing, which does not permit a transfemoral approach. Further, as we go up to the femorals, you can see that there is again severe calcification at the level of the abdominal aorta and at the level of the bifurcation. Here we can see that she has a minimum diameter of 4.4 millimeters. Yes, thank you. Next slide, please. So here is just a screenshot of our landmarks where we can see severe calcification. On the right side, we have a minimum diameter of 4.8 millimeters. There, in the middle section, we can see that the patient has severe calcification at the local bifurcation. And on the left, a minimum diameter of 4.4 millimeters. Next slide, please. Then we looked at her axillary artery, and this showed that it was appropriate for trans-axillary approach with a minimum diameter of 5.9 millimeters. You can see, we can go through here that the artery is nice, clean, free of calcification. So we opted for a trans-axillary approach in this case.
This is something we see quite often when patients, especially women, have severe calcification in their femoral vessels. They tend to have quite a preserved axillary artery, and this is why we want to demonstrate this case for you today. I believe, personally for you as a CHIP society, this will have more of a bearing when you need to put in a balloon pump or an implant. The access and the procedure will be similar to what we do here for TAVI today. Today we'll be using a 14 French sheet, but we can go up to 18 French with this size vessel. Yep.
Next slide, please. So the procedure planning, what have we done so far? Maybe Ellton, you want to tell them what we've done so far?
Yeah.
So we've already taken right radial artery access, a 6-French sheet, and we have put a pigtail catheter in the aorta, in the aortic annulus. And then we've taken a left femoral venous sheet, 7 French. We use it for central line as well, but also for temporary pacemaker, the right ventricle. And then we've taken a left radial access, 6 French sheet, for balloon hemostasis and bailout stenting if need be. So this is so far. Matt will show us now how to take the axillary access.
So after we've taken the ipsilateral access in the radial artery, what we usually do is we do an angiogram of the subclavian and the axillary arteries, and we'll be able to show you that because we've just done it. The next slide. This is some pictures from our previous one, and you're not able to see the room right now, but this is the setup of our room. So the screen is on the opposite side, and we are standing on the left side of the patient, as opposed to the right side of the patient. We keep the arm outstretched at between 45 and 90 degrees, as you can see. And this is very good because it tends to change the angle of the axillary artery, bringing it more superficial and straighter, making our access easier and even the passage of our large sheet easier, avoiding kinks. Next slide. So we're showing you a bit of a picture of what the anatomy of the axillary and the subclavian arteries are like. Now, the axillary artery is outside of the chest, the subclavian artery is within the chest. So you definitely want to take the access of the axillary artery. Moreover, from anatomy, we can divide the axillary artery into 3 segments. Segment 1 being most proximal, segment 3 being most distal. And we want to hit A2, which is the middle part of the axillary artery. Why do we want to do this? 2 reasons. First of all, we're further away from the thorax, so we are less likely to cause a pneumothorax. If we have a bleed or failure of hemostasis, the bleed will be easier to control because we can compress the axillary artery against the chest wall and the ribs. Whereas if we go deeper or more proximal, it's more likely the bleed will be within the chest, it will be occult, it will be missed until quite late on. We don't want to go too distal, so we don't want to hit A3, because if we do that, we have the major important axillary nerves there, and we can cause nerve block and nerve damage. So really and truly what we need to identify when we look at the angiogram, and we'll show you this quite soon, is we want to find the scapular artery, and the subscapular artery, and the lateral thoracic artery, and we want to hit somewhere between the 2. Okay, so that will give us a nice bearing of A2. Next slide. So these are myself and Dr. Pllaha. You can't really see us right now. It's a pleasure to be with you during this conference. Next.
Okay, but this will
we'll get to at the end. We'll show you how to do the closure at the end. Okay, so what we're going to do now is we're going to show you the angiogram, please. Can we show the subclavian artery angiogram? So this is using a 5 French pigtail. Okay, and as you can see over here, very easily identifiable on the right-hand side of the screen, going down towards 5 or 6 o'clock, we can see the subscapular artery, which is the larger vessel that's going down. So that identifies the beginning of A3. You can also see the lateral thoracic artery, which is around 2 centimeters more proximal than that. So we want to really hit somewhere between the 2. So our landmark could be angiographically the middle of the scapular head. Okay. Now, of course, with each patient this changes, and we also want to make sure we take the guidance using ultrasound. We want to make sure we have a clean puncture, and we want to make sure we identify the difference between the vein and the artery. So what I'm going to do now is I'm going to do an ultrasound of the artery, and I'll take you through the different parts of the artery, show you the different anatomical landmarks, and we'll take access. Can we have the head of the AI up, please? And can we show them the ultrasound large screen, please? Can we increase the depth and change the gain? Okay, so let's show you. Can we change the gain, please? Yes. So, all right. Can we increase the depth? Yeah. So here we can see the vein, which is compressible. Okay, that's the axillary vein. And next to it, and maybe just slightly deeper, we can see the artery. We're giving up few tributaries. So the vein is the compressible one because it's open color Doppler one. And the artery is the pulsatile one, of course. So we can easily identify the two vessels. If we come more, come more distal, the vessel becomes deeper, and you can see more of the white nerves coming across and in front of the vessel. So we want to go a little bit higher. If we go even higher, then we can see that there are the ribs starting to show on the ultrasound, and you can even see the pleura just below the vessel. You can see this white line. That's the pleura. We perforate that, we get a pneumothorax. So we definitely don't want to do that. So here in our hospital, we'd like to take it in this view, in the sectional view. So what we're going to do now is we're going to introduce our needle and take access. We also see the pre-fit catheter in the artery. Yes. Can you see something white there? That's the pigtail. We can see. Okay, so we have taken access. Now, there's two ways of doing this. You can use a micropuncture kit, or you can use a normal Seldinger puncture kit. We found that we prefer to use the Seldinger puncture kit, especially because some of our patients tend to be quite large. And the micropuncture kit can lead to problems with reaching deep enough. Okay, now I'm going to do a small blunt dissection. Then artery forceps down to the vessel wall, and then we can insert our 6 French sheath. Again, the elegance of this procedure is that we're staying outside of the chest, so that increases the safety. And at this point in time, we can do some fluoro to see where we are with our wire. Okay, so we can see we're nice and within the axillary artery going down to the descending. Okay, our next step is to prepare for the closure of the procedure. Now over here we like to do one ProStyle, one Angioseal. So we'll use one ProStyle device and one 8 French Angioseal when we come to close. For now, we need to deposit the ProStyle. So we'll do that, and then we'll upgrade to 10 French. It can have 3,000 units of pepper, please. Another 3,000. Yes, thank you. Okay, so we just make sure that we're going in the right direction with our wire. Yeah, we're in the descending there. That's a very nice, safe place to be. We want to lift the II, guys. We want to maybe show our hands.
Just a short question, Matthew. I guess you use this with Edwards sheaths, and did you ever do one of these? Do you never use the other ones where you have to exchange the sheaths?
So we're not using an Edwards sheath, actually. We're using an Evolut sheath. So our device today is going to be an Evolut device, not an Edwards device. So we will be using a sheath by SMT, I believe, right, guys, today? Correct? Yes, the central sheath.
So, but the valve. So, with the Evolut, I think that's the one where you have to kind of exchange the whole system with it.
Yes. So with the Evolut, what we like to do here locally is we like to cross the valve first and then upgrade directly to the valve sheath itself. So the Medtronic sheath itself. And then we will be inserting a 14 French sheath to replace this later on.
Okay.
Does that answer your question?
Yes,
Can
thank you.
we show them the sheet that we're going to use, guys? Yeah. So this is the sheet that we're going to use today. So it's a 14 French sheet. We'll be upgrading this later, however. So for now, we're just going to upgrade to 10 French. And then essentially we can go from 10 French either to 18 French or to 14 French, depending on what type of device we're going to use. This patient is suitable for a 29 millimeter Evolute Pro Plus device, which is what we're going to be using today. So the sheet size is 14 French.
So how do you decide? In your first slide, where you said your plan, you decide either 1 or 2 proglides.
Yes.
What is your technical kind of decision? I want, one is enough, and you're happy. How do you check that the one proglide is employed well?
So with when it comes to the decision about proglide, so we have two different approaches. Some operators prefer to always use two pro styles. Personally, I prefer to use only one pro style and one angioseal when I'm going up to 14 French. When I go to 18 French, I prefer to have 2 pro styles in place just in case. And if the vessel size is very large, I also prefer to have 2 pro styles instead of 1. But it is mostly experience that has taught me this. When it comes to axillary approach, your ipsilateral radial access is your safety. So essentially, whatever goes, if anything happens and our pro style doesn't deploy well and we don't get hemostasis, we have access and a wire across the vessel. So we can always put a covered stent if we need to. And we have in the past had failure of closure with 2 pro styles, and we have been able to close this using a covered stent. As a matter of fact, we have got on standby an appropriately sized covered stent ready to go just in case we get failure of hemostasis at the end of the procedure.
Are there any special requirements for your covered stents there? Like, in the femorals, you've got all these bendings, kinks, and worried about. In the subclavian area, do you use also?
So we of course have seen the anatomy both on fluoroscopy and angiographically, so we know that there's no significant calcification. We've punctured the vessel in a place where it has no major tributaries. So we know that we're not going to be covering anything. If we had to put covered stent, we're not going to be covering any major branches and causing any ischemia to the nerves or any of the structures in the chest. Moreover, the sizing has already been done. So based on our CT, we know that we need to use a 6 millimeter covered stent, and we know that the length is going to be about 40 millimeters in length. So we have that stent ready just in case, ready to go. This is all part of the pre-procedural planning. So we always have a bailout ready just in case, especially for procedures where it's a little bit harder to get hemostasis than using a femoral approach, for example.
And all your covered stents, they pass through the 6 French guides.
So we have a 6-7 glide sheet here in the radial. Because if the stent was larger than 6 millimeters, we would need to put a 7 French sheet. So if we had to put, for example, an 8 millimeter balloon or an 8 millimeter stent in there, we'd have to go with a 7 French. So up front, I always go 6-7 glide sheet from the radial artery.
Brilliant. I'll just ask the audience, just come forward and comes forward if you have any questions, please. Yeah, just don't hesitate to ask.
Yes, please do.
I think you can go on. And just to warn you, you've got a big competition in our local cath lab. Cambis does another trans-axillary access as well. So,
all right.
But you're doing very well. You're doing very well.
That's interesting. Thank you. Let's move on and proceed with our TAVI. And then, feel free to ask us any questions as we go along. Super. So,
maybe, if I can ask a question. For the secondary access, for the pigtail in the AV, do you use the ipsilateral access as well, or you have a secondary on the
We have
control axis?
right radial for that because we prefer to have the ipsilateral axis as a safety at all times, just in case something goes wrong. So we've got right here. You can see that we've got we've got right radial access for our injection during the TAVI.
Consider there is like a very difficult access, and you do not have right side access due to kinking or occlusion of the subclavian on the right. Can you use it in parallel, or could you?
Yeah, you could. Just make sure that you never at any point in time lose your wire across the access site. That would be my advice, but you can go ahead and do that, yes. In this case, the patient had very good radial arteries, so we thought there was no harm in going ahead and using both. But certainly, if you've got any issues with the right side, or for example, you need to give access to anesthesia department, we can definitely use your ipsilateral side. Just make sure you don't lose access at any point in time across the puncture site, because if so, you then lost the point of having a protective ipsilateral access. Just straight into the lenses, and can we go to LAO? So can we also take an ACT, please? I think. Thank you. So we can see the valve is quite calcified. We're going to take an AL1, an unplugged step, one across the valve now.
Can I ask something in the meantime? I stopped doing TAVRs for a couple of years, focusing on CTO and chip, but I see that the technique of crossing the valve has not changed. Is there not any device that centralizes your wire that makes it more predictable to just cross it immediately, or are we all just trying?
We don't have the device locally to do that. I know that there are a few available on the market, but maybe you want.
I'm just asking because there used to be a device called Centocross, but that was done for crossing CTOs in the center. Never worked because it's probably not ideal to cross it in the center. That would be something that could be applicable here.
3,000 more units have been going.
It's obviously not a need, so they will cross soon.
No, it's not an easy valve to cross, and coming from the left also makes it a little bit harder.
The orientation is.
Yeah. Even as an operator, it's not the most comfortable place to stand, looking backwards.
It's straight, yes, that's what it is.
Yeah, okay, cross. Yeah. Can you slush blue, please? Can you come up with the layout?
Okay, flushing blue. Flushing.
So, spontaneous pressures.
Zero volt, please.
You can zero both.
Here, close.
Close. Tell me when. Okay. It's not zero. So you can see. Wait. We're having just a slight issue with our pressure system. We're just trying to re-zero the pressure inside the ventricle, and then we'll be able to check the gradient across the aortic valve. In the meantime, our valve has been crimped and prepped. It's ready to go. So what we use next is a Neoe wire. All right. There you go. Last zero will get through. Can you flush, please, guys? Flush the blue. Flushing. Shall we take another ACT or not yet?
1 minute. 2 minutes, probably.
But that's wrong.
So, während wir da warten, kann ich nur fragen, wer ist, in welchen Zentren werden Tavis da gemacht? Könnt ihr die Hände aufzeigen? Also die
Okay, so we've got the gradient across.
Wenn Sie wirklich Fragen haben, einfach nur wegen der Tavis, so einfache, dann einfach nach vorne kommen oder fragen. Ja. Das ist, ich glaube, dass dieses Wire Crossing, das was der relativ schnell gemacht hat, das ist das Frustrierendste an der ganzen Tavi. Ja.
Equivalent to the echo. Now, we're going to take our Inoue wire, so it's a double curved wire.
It's the complete opposite of PCI. Distal radial access you get within 2 seconds. You spend all your time on lesion preparation. This lesion preparation will hopefully just take a second or not even. Sometimes you just do primary stenting. And then we try to not put stents anymore, and there's obviously going to be a stent there. But still, we can learn from each other because I think access is good, and the Combis shows actually a CTO PCI where you need this axillary access, and you know how to perform it.
So, Matt, what type of wire is this? It doesn't look like sapphire.
It's an Inoue wire, so it's a double curved wire. It's our current workhorse wire for Tavi. This is the small curve because it comes in different sizes depending on the size of the ventricle. And this patient is quite a small patient. She only weighs 49 kilos. She's quite small. So can we have the valve, please, guys? Okay, so this is our Medtronic Evolute Pro Plus size 29. We're going to screen it to make sure that it has been crimped correctly. Okay. Yeah, so we can see all of the different struts look all right. So we're ready to insert our device now. So can I have the cut here?
So, für die Leute, die das nicht sind, da gibt es einen Safety-Check, dass es so richtig gekrimmt war, und das machen die unter Fluoroskopie.
Ja, also man sieht dann diese Rompen des Gerüsts und glaube ich 3 oder 4, maximal 4 dürfen überlappen. Und die Idee dahinter ist, dass es kein Infolding gibt, dieser Klappen, dass die nicht übereinander liegen und dann nicht richtig entfalten. Und wir hatten 1-2 Mal so ein Problem, wenn der Cage sich ausbreitet, dann kann es eben auch sein, dass er sich nach innen ausbreitet. Dann hat man so praktisch eine nierenförmige Shape und so funktioniert dann die Tavi nicht. Das heißt, wenn man das Sleeve wegzieht, um sich zu expandieren, dann muss natürlich die Radialkraft nach außen gehen. Wie, ob man es da sieht, vielleicht nicht. Wir können sehen, es gibt so wie ein bisschen dunklere Linien. Das sind diese Cells und die oben 3 müssen auf jeden Fall alle entfaltet sein.
So, Matthew, just one question. So usually when you go from femoral, you do in the descending aorta, you do your aligning. When you come from the top, so do you have to do it somewhat differently, I guess?
It's exactly the same. So the approach actually is very similar because you're still coming around the bend from the left. So that's the way that the ascending aorta goes also. So we actually align in exactly the same way for coronaries.
But now you look kind of downwards. So when you align, is it not on the way up usually with the evolute?
No, so with the evolute platform, the alignment is carried out on how the device is inserted into the patient. We keep the side flap at 3 o'clock as we come in across the valve, and that's what we're doing here. So we can't show it to you because it's behind all of the equipment, but they're aligned at 3 o'clock. So we have good coronary alignment this way when we have deployment of the valve. Hat markers on the outside. Yes. Also, you can see the hat marker on the outer curve of the aorta, which is what it's meant to be. And like that, can you give us the contour? Okay. So as you can see, we're really ready to start opening at this point in time. Can I ask you to pace at a rate of 110 per minute, please?
So this new evolute valve has got like these openings towards the coronary arteries. So it has to be put in so-called aligned. So when it opens up, you've got a free access with a guide to the coronary, cusp and coronary. So, Sie können sehen, dass die jetzt pacen. Ja. Bei der Evolute müssen Sie nicht so schnell pacen wie bei dem Ballon Expandable. Ja. Also die pacen meist so mit 120 oder so, oder da sogar 110. Ist nicht so essentiell wie bei dem Ballon, wo man den Druck wirklich runter auf 60 oder nieder, damit sich das jetzt gar nicht bewegt, ja, weil das wirklich innerhalb von Sekunden. Hier wird das einfach nur verlangsamt.
Ja, du hast eigentlich dauernd Fluss. Zuerst paravalvulär und jetzt durch die Struts und erst ganz am Schluss.
Schaut auf den Druck, da ist ganz kurz, wenn Sie nicht Fluss haben, und das ist ganz kurz, ja, aber da muss man schauen, der Druck, wenn Sie schauen, und jetzt ist wieder Druck, ja, aber da war kurz, auf die man nicht zu lang bleiben sollte. Ja. Aber bevor man das sozusagen loslegt, ja, kann man das immer noch reinziehen, obwohl der Fluss die ganze Zeit sonst ist. Ja. Ja, jetzt kann man immer noch reinziehen, ja. Das ist halt der Vorteil.
Also wir versuchen die auch möglichst hoch abzusetzen wegen Schrittmacherrate. Und das korreliert ja mit der Tiefe der Klappe. Und uns passiert noch ab und zu mal, dass sie oben rausspringt. Und da kannst du noch mal reinziehen. Es gibt so einen Ratchet-Moment, also du drehst am Handle, bis er dann praktisch anfängt so zu überdrehen. Und dann ist der Point of No Return. Das ist noch ein bisschen weiter als das, ungefähr so weit. Da kann man sie immer noch reinziehen. Und jetzt, wenn die erste Krone rausspringt, jetzt ist vorbei.
Jetzt wird's losgelassen.
Jetzt kannst du nur noch snaren. Jo, kann man auch noch. Und das ist auch der Grund, warum die Klappe oben so ein bisschen reingeht, damit die Struts eben nicht ins Endothel ragen, dass man da an diesem einen Post kann man dann mit der Snare angreifen und dann an diesem Panhandle und die nochmal hochziehen.
Can we bring up the slide again to show them our final slide? So essentially the TAVI procedure is done. We have good deployment of the TAVI. What we're going to do now is we're going to show you the first part of what we're going to do for hemostasis. So we have got a balloon up on the ipsilateral approach to occlude the vessel as we exchange sheets. Okay, so right, we start short then. If you want, you can lift up the II, guys.
It's an absolutely perfect result. Congratulations with your valve
Thank
deployment.
you very much. Yeah, so we're going to take a 6mm by 40 balloon. Sure. So it's a peripheral balloon, essentially very similar to what you use for coronaries, but larger, of course. We're going to place it somewhere here anatomically. Can you show Brian a bit? Okay. So when and we're going to inflate it as we remove the device to cause hemostasis, so that we don't get a lot of bleeding as we go along. So Dr. Pllaha Ellton is going to do that right now, and then we'll be able to walk out our Balbi device. Okay, can you bring the eye down again, guys, so that we can screen a bit? Yeah. Okay. Come in.
Shall we switch them?
Yes, can you lift for a second? Okay, so our balloon at this point, of course, is stuck, and this is where we start to walk out. So we don't lose the wire, please. Guys, can we show us more on the screen? Thank you. Not this one, the big one. Look at here, big.
For the technician, can you make the bottom right image, the angio, really big? We just need this one, please.
It's from them. It's local, I think.
Like this. Yeah.
Ah, perfect. Thank you.
Okay, so here. Can you just make sure we're not coming out with the wire sheet logo?
The chala.
Yeah, now show us back up. Yes. Okay. There's a balloon in.
Man sieht dann den Cone, dann das, was gerippelt ist, ist die Schleuse, wo die Klappe drin war. Dann dieser schwarze Punkt ist praktisch da, wo die Posts verankert waren. Und dann kommt die Schleuse, die da noch drin steckt in der Subclavia. Und da beim proximalen Ballonmarker geht sie eigentlich aus dem Gefäß raus. Da kommt ein Finger und dann jetzt ist die ganze Klappe raus.
So, Matt, so do you have to kind of do this kind of quick exchange? They wouldn't pass next to each other in the small artery. Is this?
Yes, that's right, because this vessel is a little bit too small. But the elegant thing is, if we can show Brian, there's absolutely no bleeding whatsoever, even though it was a little bit flow. And there's Brian, can you show with the camera? Yeah. Down here.
It's a beautiful demonstration, absolutely.
Great. Okay. So now we can put just some minimal pressure and we can walk out. Then, as opposed to having a flush of blood, we have very minimal ooze. So we found that this is quite an elegant way of controlling the bleeding, because when we've not used the balloon, we've had quite torrential bleeds while we exchange from one sheet to the next. In TAVI, we need to exchange sheets now, so that if the valve needs to be adjusted, it will be adjusted at this point in time. So, yeah. Yes. Can we screen again, please? Thank you. No, we don't.
Why do you reinsert another sheet? Could you not just close it right now?
Yes, but we always, with TAVI, we must always take simultaneous pressures. And unfortunately, the Medtronic system does not allow to take simultaneous pressures with valve is still inside. So we need to remove the valve, put a large sheet in, and then we can take simultaneous pressures. So we need to adjust the size of the device by post-dilatation, which I don't think is going to be the case in this case, but if we need to adjust the size of the valve, we have to do so at this point. So what we're going to do now is we're going to take a pigtail into the ventricle, so we can assess, make sure that we have no gradient. At that point, we will also take an aortogram to make sure we have no significant paravalvular leak. Can you see the apex, please? Apex.
Das war sozusagen meine Frage vorher wegen diesen Klappen. Mit Edwards müsst ihr das nicht. Ihr habt einfach eine Sheet, Klappe rein, macht alles fertig, alles raus. Bei dieser Evolute, ja, ist es ein bisschen mühsam, zuerst eine Sheet, So dann rein über die Valve, dann diese Sheet raus, dann die Klappe raus. Das ist das Blöde. Wenn die Klappe rauskommt, kommt diese Sheet mit heraus. Und wenn ihr was anderes über den Sapphire oder den Sie haben wieder machen wollt, braucht ihr eine andere, wieder diese alte Sheet wieder rein. Das ist bei der Evolut ein bisschen mühsam, dass die Klappe fest mit der Sheet ist. Das heißt, die Sheet kommt sofort raus, wenn sie reinkommt. Und das ist, glaube ich, dieses Spiel zwischen Ballon und Sheet rein und raus mühsam. Ich glaube, dass bei der Evolut wäre das viel einfacher, wo einfach Sheet rein bleibt und ihr könnt es einfach rausdrehen, rein und raus.
Für den Simultandruck könnte man ja einen Dual-Lumen-Pigtail nehmen, aber wenn jetzt noch ein relevantes Leck ist, kann ich natürlich nicht nachdrehen, wenn ich dann zugemacht habe. Da muss ich jetzt nochmal ein Sheet rein, nochmal punktieren. Macht schon Sinn, nochmal zu warten.
Yes, thank you. Yes, that's zero. That's the flash. And the zero of the red is probably not as well. Yes,
That's 0 again.
Yeah, we have no grid. We have no grid. Good. Okay, so there's no significant gradient here across the valve anymore. As you can see, there's overlap of the blue and the red curves. What we're going to do at this point now is an autograph. So can you feel a bit contrast?
Sorry. Yeah,
Okay, so that's an excellent result with the Tabi. So the sizing is perfect, coronary access is great, and we have no paravalvulity. And the skirt is just 3 millimeters below the annulus, which is exactly what we were aiming for. So I think we can be very happy with this end result. Of course, when we flush, you can see that there's absolutely no gradient across the valve anymore.
Absolutely perfect, yeah.
Any questions from your end, sir?
If you just can show us basically the closure now, so and then we will switch over, I think, to Cambis.
Yes, let's do that. So can we have a wire, please? Okay, so pull back the wire. Send it. Then we're not able to do the same. Yeah. Yes. Okay, so we're putting our wire into the descending so that we won't interfere with the Tabi. Okay. So let's pull the balloon a little bit back. Yeah. Okay. There. Yes, deflate it through, please. Yes. Can I have the knot pusher, please? So we've got our knot pusher ready for the pro-style closure. And Ellton's going to walk out the sheet while the balloon is inflated. Yeah, walk it up, yes. Okay, so you can already see the knot has worked. We already have very good hemostasis here. Can they see, Brian?
Yeah.
So just by pushing down the knot alone and with the balloon inflated, we have excellent hemostasis actually. What we do next is we're going to take the 8 French angiosafe. Yep.
So you don't check in between, just deflating the balloon briefly?
Check the very end then. We're quite confident with that the bleeding, since we punctured external to the chest, the bleeding will be coming out. So we're not particularly worried about that. So now we need to deflate our balloon, please. As we come in with our pro side.
So this is our angioceal. We're now going to lose the wire. Yeah, so now we're going to pull back our angioceal, seal the angioceal, and at the same time, we're going to come back with the balloon slightly over the angioceal, and we're going to inflate. So we have a compression of the angioceal against the balloon. Yeah.
I really like this, and this is like one good tip. I think femoral the same. Some people do, the TAVI operators. That if you got a cross over balloon or something, and your manta or angioceal didn't work, you can balloon it from inside from another axis, just to try to alter a little bit the position of this plastic foot. Yeah.
Now we can lock the suture of the profile, and we can deflate the balloon, and we can see whether we have good hemostasis or not. And I always like to end this, since we're in the chest, or just outside the chest.
I would like to know, what is the balloon size you have been using for the axilla?
It's a 6 by 40 balloon.
Ah, super, thank you.
Okay, so now we're going to take a pigtail and shoot an angiogram of the subclavian artery. This is mostly for our own peace of mind. There is absolutely no bleed present. Okay, so now you're going to show us the same things we did before calculating. Okay, so yeah, excellent.
Is it PCA?
Yes. Correct. Yeah. Go. Wait, let's repeat it, because there was a filling here. Go. Okay, so you can see preservation of the branches and no bleeding present. Of course, we have an angioceal and a procile, so there's a bit of narrowing of the vessel now, which should heal naturally as the absorption of the collagen plaque occurs at a later time. I think we're happy at this stage. We will just walk out the sheet, and then put the TR bands on both sides, and we're happy to go. Any questions at this point?
Any questions from the audience? Matthew, Pllaha, this was an absolutely brilliant demonstration of trans-axillary access. I'm so grateful to see this. And you are a great team, and you've demonstrated Malta is not just for holidays and English courses, but if you want to get a great TAVI, there's a team for you.
Thank you so much.
Thank you so very much, and for the entire effort before this entire Congress which you had to do. And I hope that we'll see you at some point in Austria as well, and maybe as proctors.
Also. Thank you. Thank you very much. Thank you, Konstantin.
Thank you very much. All the best. Back to Malta.
Thank you.